In my practice, I order molecular testing at diagnosis. Molecular testing in colon cancer has a huge impact on the management plan, and therefore having the information early on in the course of disease is key. The minimum amount of molecular testing that we need to manage a patient would be testing for microsatellite instability. Number 2, extended RAS mutational panel. Number 3, RAF mutations. These are the minimum amount of molecular testing that we need. In my practice, I tend to do next-gen sequencing because that gives me those 3 minimum things that we need, in addition to a whole number of other genes that could have impact down the line in the management of these patients. RAS testing is needed for all patients with colon cancer, regardless of the sidedness of the tumor. Although in right-sided tumors, the impact of RAS testing is not in the frontline setting, but it may have impact on management in the second or third line setting. So that's why I believe everybody with colon cancer needs RAS testing. NTRK fusions are present in a small proportion of patients with colon cancer. However, when we identify patients with NTRK mutations, there is option of doing targeted therapies that have shown to be very effective in that small subset of patients. And that's one of the reasons why doing a more comprehensive next-gen sequencing approach would provide the information about uncommon mutations like NTRK early on in the course of the management of these patients and allow us to develop a management plan that will incorporate those drugs either in first line, second line, or third line. For a long time, we've known that tumor sidedness has an impact on the outcome of patients independent of the treatment that they receive, and in that sense, it is a prognostic indicator. Patients with right-sided tumors tend to have a worse outcome than patients with left-sided tumors. In addition to its prognostic value, sidedness of the tumor has an impact on responsiveness to certain therapies, specifically EGFR inhibitors, and in that sense, it is a predictive marker. We know that patients who have right-sided tumors should be treated with chemotherapy plus bevacizumab in the upfront setting and not chemotherapy plus an EGFR inhibitor in the upfront setting, regardless of KRAS and BRAF mutational status. Right-sided tumors, we should start with bevacizumab as a targeted drug, and in that role, the sidedness of the tumor is predictive.